there, my name is Jordan Duda, and I'm a doctoral candidate at Maryville University, and this is my final presentation. And it is over Cetuximab hypersensitivity reactions in residents of the Midwest United States. So to kind of dive right in, what is cetuximab? So cetuximab is a monoclonal antibody indicated for use in patients that have head and neck cancer or advanced colorectal cancer. There were some other indications at the beginning of this project, but they are no longer indications for cetuximab. And so even though monoclonal antibodies are generally known for adequate response with respectable tolerance, cetuximab is kind of a unique one in that type 1 IgE-mediated hypersensitivity reactions are very prevalent, especially in the Midwest United States. So nationally, around 2 to 5% of patients will have some degree of hypersensitivity reaction, but in the Midwest, that rate is upwards of 22%. Simple symptoms can be as simple as facial flushing, headache, real simple things, or it can be as distressing as, your throat swelling, closed, chest pain, cardiac arrest, and even death. One of the recent theories around why it's so prevalent here in the Midwest United States is that we have Lone Star ticks in this area, and these ticks act as a vector for alpha-gal, the oligosaccharide, basically to transfer and cause allergic type reactions. They think about it for red meats and things like that, but the way cetuximab is made actually very similarly replicates those proteins and therefore has that cross antibody contamination. So what we can do to help with that situation is the whole purpose of this project. So national guidelines, basically, on the information packets for cetuximab, and talking to the National Comprehensive Cancer Network, NCCN, they have guidelines on how all their drugs are to be given. Cetuximab's guideline is basically to give a histamine 1 antagonist, so Benadryl or something along those lines. And that's really it. And where this project was done in the Midwest United States, it has an infusion center policy that basically just says that, give an H1 antagonist if it's ordered, and then give the drug. That's the extent of the policy. It's very, very bare bones, but technically it is in alignment with what the NCCN guidelines are for this drug. However, that's nationally. It doesn't necessarily address this local phenomenon. So doing some research and looking into all of the best practice evidence that's out there currently, really you should be doing at least that H1 antagonist, but also adding an H2 antagonist like Pepsid into the mix, and then throwing in montelukast, which is the leukotriene receptor antagonist. And doing the project and working with the team at this cancer facility, it was kind of found that the providers didn't necessarily meet these best practice guidelines perfectly. Originally, the design for this project was to do a pre-post design, so where we could do, measure the data from what they were doing before, get them all on board, add the montelukast in there, and then retest and see, did we see those rates drop? That unfortunately wasn't able to happen. I was able to get support from the facility to do the research and things like that based off of what the providers currently were doing, which we'll go over in a second, but not necessarily I didn't have the backing from the providers necessarily to change the pre-medications that they liked doing currently. However, with the results of this project, we'll go over those together here. I am going to present those to leadership and to the physician team for consideration, so that way maybe they could see, we've made some good progress, but here is what the best practice evidence says. And just so that way you guys are aware, the providers did do the H1 and H2 antagonist, but they did a corticosteroid, which is in some literature as helpful for preventing fevers, facial flushing, things like that, but isn't necessarily considered a mainstay of preventing the true hypersensitivity reactions, the cutaneous and respiratory effects that we talked about. With that being said, there were really two main goals of this project after we kind of reworked, knowing that we couldn't change the medications at this point in time. So goal number one was to decide if the number of hypersensitivity reactions this facility was seeing is lower with the provider preferences than what is typically seen in this region. And number two, to see if the number of hypersensitivity reactions at this facility was comparable to rates seen nationally. That being said, we had to have a way to measure that. So I did create a data collection instrument that was presented to the Maryville IRB before ever starting the project, and that did include demographic information. It was basically made to where nobody could ever take this form and figure out who I was talking about, but did collect information such as their diagnosis. I did track a general age group within decade, and then also their sex or gender, things like that, just so I could see if there were any patterns that I wasn't expecting. But that information was included. I did also keep track of what pre-medications they did receive, because providers were pretty consistent, with the exception of 2 patients. They were very consistent about doing exactly what we had recently said was their favorite. So doing the H1 antagonist, doing the H2 antagonist, and then also the corticosteroid that they were a fan of. But none of the patients included in this study got montelukast, which is what the evidence-based practice says you might consider including. To expound a little bit further about what data I included, I did include if they had an infusion reaction, and then I also included what grade the infusion reaction was, and that's based on the United States Department of Health and Human Services. They have a common terminology criteria for adverse events grading scale, with 1 being mild, 2 being moderate, 3 being severe but not life-threatening, 4 is life-threatening, and 5, they died. Luckily, we had no patients in that category. But I did include an option 6 as well. That just meant it was not applicable. They did not have a reaction. If patients did have a reaction, and the grading is in there, I did include what interventions they needed. So whether they needed to be given albuterol, if they needed more steroids, if they had to be given more of an H1 or H2 antagonist. Did they need CPR? Did they go to the hospital? Or did they not need anything because they didn't actually have a reaction? I did also include whether the reaction was resumed or, could they ever come back to this drug? But it was found that every patient that had a hypersensitivity reaction to this drug, they stopped the drug, it was not retrialed, and they did not receive any further doses. So those that did not have a reaction received the full several courses of the drug, but those that did, all of them experienced the reaction on their first dose, and all of them were stopped immediately. With this data collection and our specific goals in mind, the idea was to decide if the provider preferences were essentially effective, and they would be deemed effective if the rates were, the hypersensitivity reaction rates at this facility were significantly reduced from what we know is the reaction rate in the Midwest United States. So we wanted to make sure that the reaction rates were significantly lower than that 22%. We'd also say that, what they're doing is sufficient if the rates were statistically indifferent from what we know about the rest of the United States. So if we could get the numbers close enough to that 2 to 5% range that, says that their data, what they're doing right now is indifferent statistically, really then what they're doing we can't argue with. So that was kind of the 2 ideas there. Either it's effective at what our goal was of reducing the reactions, or is it sufficient? Do we need to keep doing anything more? And our results were kind of interesting. We only had 47 patients from a time frame of 2016 to 2022 that did receive cetuximab at this facility. However, that being said, that was enough patients to actually get some pretty moderate to high level power studies done. And so of the 47 patients, 5 of them did experience a hypersensitivity reaction. I don't know exactly what it means. This could be for something for later research, but all 5 of them were males. And as you can see in my data table, I did have males and females of each diagnostic category, but only males reacted. So that total of 47 patients, 14 had colorectal cancer, 28 had head and neck cancer, and kind of have it broken down into the tables here on which one, fairly even between the 2 diagnosis types of which one reacted, but only males reacted to the cetuximab. So we used a lower tail z-test against a constant, which our constant was the 22% for the regional data, and the basically 2.2 to 2.5% average of what the entire United States is. That lower z-tail lower tail Z test was used for the regional data, and it was found actually that current provider preferences for pre-medication administration do result in a statistically significant reduction in the rate of hypersensitivity reactions. As you can see there, that was a Z of negative 1.8803, which did give us a confidence of 0.03. So we were able to reject the null in that case. The two-tailed Z test against the constant of the 2 to 5% was used to determine if it was statistically different or indifferent from the national rate that we were talking about. And we were not able to achieve indifference, essentially. So we don't reject the null, but that was kind of our thought in the beginning, is do we want indifference or not? And we were still statistically different at 3.9439, and that was very high. So we still were not where we needed to be to get us to match the rest of the country, but what we're doing does significantly reduce it from what we see in this area. So that was a pretty neat finding. So what this tells us, and what, it demonstrates the importance of, is that we need to continue pre-medication interventions beyond what the current infusion policy and national guidelines say. It's pretty clear that just giving an H1 antagonist is not sufficient. It is also interesting because there were 2 patients, and this is not necessarily on the slides, but there were 2 patients that only received an H1 antagonist. They did get a corticosteroid too because the providers like that, but they did not receive the H2 antagonist, and they did have a reaction. So of the only 2 that did not get the H2 antagonist, 100% of them reacted. So that very clearly at least indicates to me that we do need to continue beyond just the idea of giving an H1 antagonist. And the data also, posits the idea that maybe we could improve a little bit further if we integrate best practice fully. So the recommendation would be to consider adding montelukast in, and essentially you have the patient take it daily for a couple days before and on the day of the treatment in order to prevent that hypersensitivity reaction. The study did have some strengths and limitations and everything like that, and the strengths were the power that we were talking about. It was a retrospective design. We only had 47 patients, but it was a sufficient sample size to make some actual statistical conclusions. The lower tail Z test had a medium in strength power of 0.616, and the power of the two tail Z test was medium to high in strength of 0.756. So this allows us to infer that the probability of a type 1 or a type 2 analysis error is really pretty unlikely. It was nice that I was able to include patients back from 2016 up to this year to ensure that I got the breadth of sample that I needed to make statistical conclusions. And one of the limitations, I would say, is just the fact that I had to use convenient sampling. This facility that I did the research at is where I work, so it was convenience and the fact that I already had access to the electronic health record. A lot of these patients I actually got to care for. They were not involved in the project, they weren't even aware of the project, so they were not contacted, which was part of the agreement with the facilities research team and also with the IRB. But I did get to see these patients. The reason why that is a limitation is this is a very homogeneous sample. You know, the area that I live is predominantly white, and that does make it a little bit concerning for generalizability to the rest of the area and nationally, because this is a predominantly Caucasian and non-Hispanic white community, and not all areas of the Midwest United States would be that homogeneous. However, some of the cancers and things like that are more predominant in the white community. So in that regard it can be, but it does provide a limitation in this regard. And also just the fact that the providers weren't interested in doing the pre-post analysis, which I think could have strengthened the study a little bit more to be able to see that sort of data. But that doesn't deter from the project at hand and the actual results that we got in this area. So a limitation, yes, but not necessarily terrible. But I think sustainability in regard to this project is, it's twofold. We don't necessarily need to keep the study going, so in that regard it doesn't necessarily need to be sustainable, but the interventions that are in place already are very sustainable. We are already giving an H1 and an H2 antagonist with a steroid. So it is reasonable to say that sustainability is possible with giving those drugs still over time. There's really no downside to stopping giving those drugs. There's really only a benefit to the patients to keep them going. And I think sustainability-wise, if they do decide to do the montelukast, is very reasonable. The generic over-the-counter for patients is, very affordable. Encouraging them to take those for a couple of days beforehand, and then the day of treatment, I think, is a very sustainable intervention going forward. The barriers for this project were pretty minimal, but we've kind of already discussed the provider preferences and things like that being a barrier to implementing the project fully, but we don't need to talk about that anymore. I think the biggest barrier that I would like to mention is just data retrieval. Even though I had access to the electronic health records, there really was not a great system in place for running a report out of that data to see who actually got the drug within that time frame. I could run reports that would tell me how many times it was given over the course of 2016 to 2022, and oddly enough, it would almost give me what looked like encounter numbers that I tried to cross-reference with actual patients, but it didn't work out super well. So I did have to reach out to some people that weren't originally on the project's design to get those reports. We have a pharmacy IT research team, and I did have to get them involved, and they were very, very helpful, and I actually included them as part of my shout-outs in the paper because they were extremely helpful. I would say that they were the facilitators, honestly, for the project. The fact that, they had access to reports that I didn't, through the EHR that I could not access, but they did. That being said, the EHR, while difficult for me, was a facilitator as well, because there was a data analysis system and a report running system that's already built into the EHR, so that way you don't have to just ask somebody, oh, do you remember who got Cetuximab back in 2017? Let's flip through some old paper charts and see what we can find. It was helpful to know that those tools were already in place. I just needed to find the right people to get it to work. So at the end of the discussion, we've talked about what we found. Is it good? Is it not good? What did we learn? I think if it's not practical and it doesn't have any sort of implications for going forward, then what was the point? And I think this project really identified some deficiencies in adherence to current best practice evidence, which is a little hard to communicate sometimes, just because buy-in is really, really important. But I think that seeing the results of the study will help convince those that were a little on the fence or a little hesitant for change to maybe consider change. So should future provider preferences identify or choose to include montelukast, we could do a pre-post test study design at that point. We know what our numbers are now, so really all we would need to do is collect the post data of, everybody's been given montelukast now, what do we get the numbers now, and compare that way. It wouldn't be a z-test against a constant, but it would be another z-test to run that. And really, I think it's very interesting to me about the two patients that did not get the histamine 2 blocker, and then them reacting as well. That really affirms that providers need to include an H2 antagonist when ordering pre-medications. So that gives us opportunities for future research, but it also leads into staff empowerment in regards to clinical practice. So because this reaction can be something as simple as facial flushing, but as severe as cardiac arrest and death, I really feel like the results of this and just that knowledge in general should allow the infusion center staff to feel empowered to talk to the providers if at least the H1 and H2 antagonists are not on the pre-medication lists. That in and of itself is confirmed by the evidence and by this paper and this project that they should be very confident in asking for those medications if they're not present. It's a matter really of safety, quality and safety for these patients, because it's scary, it's life-threatening, and it's really unpleasant for the patient and their family whenever their loved one is going through these situations. So from a quality perspective and a safety perspective, staff should really feel empowered to ask for those medications if they are not present. They could just give the H1 antagonist based on policy, but that's really not sufficient. while the current policy does technically meet the minimum criteria as now outlined by the NCCN guidelines, this project solidifies the fact that at least an H2 antagonist needs added to the policy, and they could include the corticosteroid if they want because it is evidence-based, but I would really strongly consider individuals to consider adding montelukast as well. I do have a plethora of sources from this project, and I would just like to thank you for your time listening to my presentation and for the opportunity to have done this project with Maryville University. Thank you so much.